Next one I'll talk about is the automatic transport ventilator. So this basically, you don't have to remember to breathe for your patient. It does that for you. All you have to remember is to hold the mask in place. And by mask, I mean an advanced airway. So you don't actually use this with a mask. So this is one of the ones that if you have that ET tube, like I mentioned earlier, or we're going to talk about here in a little bit a King LT or King Airway, or some other type of advanced airway device that actually puts a tube in your patient. You can use one of these automatic transport ventilators with those. The King LT is something that some agencies are allowing EMTs to do. You don't have to be an advanced EMT or a paramedic. So this is something for you guys actually to pay attention to. The automatic transport ventilator, you set the rate, you set the depth, and then it basically does its thing, and it breathes for the patient for you. The problem with this is if you're busy doing other stuff, you might forget about it. You might forget to check on them. So some of these, most of them do require oxygen. It may require, usually will require, an external power source. And you really have to monitor to assure patient compliance so that your patient is not being overventilated. Your patient can suffer barotrauma. So this is trauma because of the pressure in the lungs. So baro means pressure. So trauma because of pressure in the lungs. The benefits, of course, of this are you can set it and forget it. It delivers precise volume. It delivers a very precise rate. It can give you 100% oxygen, and it frees you up. You don't have to do anything with this. So again, the complications of positive pressure ventilation, which is what all of these have been. So starting from mouth to mask, and then you've got BVM. BVM, that's an M, I swear. You have the FROPVD and the ventilator. All of these, if you haven't, you have an inadequate mask seal, it's not going to work. You can overpressurize the patient, which can actually cause a pneumothorax, so you can pop their lung. And then the gastric inflation, which leads to gastric distension, which leads to vomit, which leads to aspiration of vomit into the lungs. So that's no good. Now, we do have to use them sometimes. I mean, there's no way around it really if your patient's not breathing, but we need to be aware of some of these complications. I'm going to put a big star here because you need to know this. I don't remember if it's really on the test or not, but you've got to know what these complications are for your patient's benefit. So understand the complications of positive pressure ventilation. So how do we decide when do we do this? Who needs assistance? Well, if they're not breathing, we need to breathe for them. The tricky part, because that's kind of easy. You can look and be like, oh, he's not breathing, I should do something. The tricky part comes with the patient who is actually still breathing and may even be conscious. We may end up having to assist them with their breathing. So who are those patients? Well, a patient who has a reduced respiratory rate and tidal volume. So maybe they're breathing 4 times a minute and they don't really have, we'll call it breaths per minute, with really shallow chest rise. And I just pulled this number out. If it's too slow for them, then it's too slow. It doesn't have to be 4. It could be a patient who's breathing 10 times a minute, maybe a child who's breathing 10 times a minute, and it's not enough. The other thing is that we can have a patient whose breathing rate is increased, but whose tidal volume is inadequate. So somebody could be breathing 50 times a minute. And if that's the case, there's no way they're getting good enough tidal volume. So they're basically, all they're doing is moving their chest wall, but not actually moving any air. So you're going to see that their chest will look like it's moving really, really fast, but if you look and watch how much it's actually moving, it's not moving enough. So memorize this. These are going to be the times when patients are going to need to be ventilated. Now, the way you're going to see this on the test is more practical to real life. You're going to be given an assessment. So you have a patient who is found unconscious, and they're breathing 4 times a minute, and it's shallow. And the question is going to ask you, now what do you do? And it's going to give you a series of choices. The correct answer needs to include OPA or NPA, and it's going to include BVM, or maybe something like mouth to mask. And it's going to need to include supplemental oxygen as needed. So that's how it's going to be tested. You're going to be given a scenario. You have a patient. Here's everything. So not only are you going to have to recognize like that they need assistance, but you're going to have to recognize when given the numbers. So hopefully that makes sense to you. We'll do some practice in class, and some of your quizzes I will set up that you have some practice with this. Okay, so a little bit more explanation. Sorry, little bunny trail there. So patients with rapid and shallow breathing, how do you do this? You're going to explain the procedure to the patient. You're going to put the mask over the patient's mouth and nose. This is going to cause anxiety in your patient. The patient's not going to like it. Nobody likes having a mask over their face. So generally speaking, expect an anxious patient. This is where you have to really communicate with them. Explain to them why you're doing it. You understand they're having a hard time breathing, and you're going to help them. Initially, you're going to assist the ventilations at the rate at which the patient is breathing. So if they're breathing, basically squeeze with every inhale. And what you're going to do is you're going to end up increasing their tidal volume. So you're increasing that tidal volume. And ultimately what that's going to allow you to do is adjust the rate. You're going to slow down a little bit. The patient's going to feel like they're getting a nice full breath instead of taking a breath that's too shallow. So adjust the rate and tidal volume until you get adequate ventilations achieved. Now, patients with slow and shallow breathing, generally they're going to have a decreased level of consciousness. So it's a little bit easier. Place the bag over the patient's mouth, or place the mask actually over the patient's mouth and nose, and squeeze the bag each time the patient inhales. And then at some point, you're basically going to need to add some breaths in. So if your patient's only breathing 4 times a minute, by the time you get to about 6 seconds after that first breath you helped with, you need to give them another breath. And again, adjust the rate and tidal volume until adequate ventilations are achieved. One other thing, what are adequate ventilations? So adequate ventilations, as I've said before, are going to depend on the patient. But a good rule of thumb is what we would consider a normal respiratory rate, but maybe on the slower side. So 10 to 12 breaths per minute with good chest rise. Chest, I abbreviate CX, chest rise. So that is what adequate ventilations are. You also want to make sure you have oxygen as needed. PRN is as needed.